Hello, my name is Uday Popat. I am a professor in stem cell transplant and cellular therapy at University of Texas, MD Anderson Cancer Center in Houston, Texas. And I've been asked to uh, talk or how would you manage a 50-year-old mildly symptomatic woman with intermediate 1 risk myelofibrosis? And this is a challenge that we face in the field of transplant very frequently. On the one hand, you have a very curative treatment, stem cell transplant, uh, that there is no other curative treatment for this disease. On the other hand, the treatment itself entails a risk of treatment related mortality and risk of long-term chronic graft versus host disease, which may affect morbidity and quality of life. So, how does one decide? And the path that is most commonly taken is that if you figure out the prognosis of a patient, that is how this patient is going to do over a longer period, and find the patients who are not going to do well with standard therapy, maybe you can justify the risk of transplant in this population. And that's why what we are told here is that you have intermediate 1 risk disease. So DIPSS is one of the prognostic scoring system which is used to risk stratify the patients with myelofibrosis. Whereas nobody would argue about transplant for intermediate 2 or high risk disease, where median for, survival is less than 4 years. I think in patients uh, with intermediate 1 risk disease, where median survival is 13 plus years, the decision becomes even more difficult. So I would suggest that we look at it more holistically and take into account multiple factors. So first and foremost, what is the prognosis of this patient? So we just said that intermediate 1 risk disease has about median survival of 14 plus years. Next, age and comorbidities. So how do age and comorbidities play into this? Obviously, we are told that this is a healthy woman and she's young. 50 is young. As I get older, I think my age of people being young keeps on getting better, younger and younger, older and older, I should say. Uh, so at 50, she can live a long life, and therefore you do want to do an intervention. And at some point, if she's going to progress, your thoughts would be to do the treatment. But on the other hand, if you cut short her life because of treatment related mortality, that does that is going to impact her most. The other factor to consider here is that treatment related mortality, because she's young, is going to quite low in this group as well. So this is a challenging decision, and you weigh this thing. So I think one of the most important way to address this issue is if you can figure out a high risk group in this intermediate 1 risk disease, then it makes the risk of transplant justifiable. So what patients with intermediate 1 risk disease would have a high risk disease? And an international panel has gone over this and come up with some guidelines. And if somebody is transfusion dependent, one could consider the transplant. If somebody has triple negative disease, that is JAK2, CALR, and MPL negative disease, these people are at high risk, one could consider. If somebody has high risk mutations like P53, AXXL1, those patients again do become eligible and certainly candidates for transplant. If someone has high genetic risk disease, and there is a genetic risk model, uh, and if you have higher intermediate risk disease based on that genetic risk model, certainly that should help as well. But at the end of the day, this is going to the decision is going to be based on what patient thinks and how she interprets uh, what her attitude uh, 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 is to risk of transplant and risk of long-term cure with the transplant. Thank you.